to be completing a respiratory assessment on my patient next. So with my respiratory patient, I do again want to start with inspection. So I want to look at my patient's chest rise and fall and her work of breathing. So I do want to note that her chest has equal chest rise and fall, so both sides are moving equally and symmetrically at the same time with each inspiration and each expiration. I do want to visualize the chest anteriorly, and then I also do want to inspect her posteriorly as well. So again, I want to look for equal chest expansion, which I see, and you can rest back again. I am observing also for the depth. So is she having very deep respiration, shallow respirations, or normal depth? I'm noting normal depth with her. I do not note any signs of distress. There is no accessory muscle use, no nasal flaring, and I don't know any type of positioning such as tripoding. And then I'm also going to assess the rhythm of her breathing. So I do not want to note any pauses or apnea when she is taking breaths, and also any other sort of abnormal rhythms like Kussmaul's or Cheyne-Stokes. I am noting a regular rhythm with her breathing as well. I'm going to ask my patient if she's had a cough. So have you had a cough recently?
Yes.
Okay. How long has that been going on?
About a week.
About a week. Have you been coughing anything up with that?
Yes.
You have. And what color is it?
Green.
Green. And what is the consistency? Is it thin or thick?
Thick.
Very thick. And how much would you say? Small, moderate, large amount?
Moderate.
Okay. Any odor that you've noticed to that?
No.
Okay. So next time you spit something up, let's get that in a container and we'll have that sent off for testing, okay? All right, so I also do want to note skin condition of the chest wall again. So I do want to expose my thorax and the posterior back as well. So I'm looking for skin condition, any lesions. Color is very important with respiratory for oxygenation, temperature, so warm or cool. And then any types of lesions, masses, tenderness, and especially any type of subcu air if my patient is in respiratory distress, if they have a chest tube, if they are ventilated, anything like that, which she is not, and I do not know any of that. So now that I've inspected the chest wall, I'm going to auscultate next. So I'm going to use the diaphragm or the large side of my stethoscope head to listen to right and left lungs both, comparing the whole time. I'm also going to break my lungs up into thirds. So I have my upper lobe, my middle lobe, and my lower lobes. When I place my stethoscope on my patient, I want the diaphragm directly in contact with the chest wall, and I'm going to listen for one full inspiration and one full expiration at each placement. I'm also going to listen laterally. And I'm going to have my patient sit up or roll over, whichever is easier for her. And again, chest wall, inspiration and expiration. Okay. Her lungs are clear to auscultation, and that finishes the respiratory assessment.